tidak terdengar Ibu Love.
Okay. How about this? Can you hear me?
It's so very small.
Okay.
Speak loudly.
Now?
No, same.
Belum.
Still the same? Okay. How about now?
Better, but still very far.
How about this?
That's
This
good.
one. Yeah. Okay.
That's better, right?
Yeah.
Okay. Well, okay. Maybe we can start now. We have 97 participants at this moment. Excellencies, distinguished ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Peace be upon you. Good afternoon. We are delighted to welcome you to the virtual parallel symposium from Indonesian Public Health Higher Education Network, or we call it IPETRGAMI. First of all, I would like to introduce myself. My name is Loveria Skarini from Indonesian Public Health Higher Education Network, and I will be the MC and also moderator in this session. It is an honor to me to introduce and welcome our speaker. The first one, of course, the chairperson of Indonesian Public Health Higher Education Network, Ibu Dr. Agustin Kusumayati, MSc, PhD. Good afternoon, Ibu Agustin. And the second one, we have Dr. Safi Buyan, MBBS, MPH, MBA, FRS, PhD. Good afternoon. And then we also have Mr. Calvin S. Delos Reyes, PhD. Good afternoon, Mr. Calvin. And also we have Professor Dr. Yawen Bedichu. Good afternoon, Dr. Bedichu. Yeah. And also, I would like to say welcome to all participants of this parallel symposium. And this symposium focuses on adaptation and innovation on public health education during disruption era. Before we start our agenda, I would like to inform you about the rules of this webinar. If you have any question in this session, please do not hesitate to write your question into our question box. Please do not write the question in chat box because we cannot see your question. So I just remind you again and again, don't forget to write all of the question in question box. And then if you want to ask directly to our speaker, please raise your hand and we will promote you as a panelist. So don't forget to open your camera so we can talk directly to our speaker. Last but not least, you'll also please also fill the link for list of attendance in this conference because it's related to our certificate today. And then the link will be shared around 4 p.m. Okay, let us now begin the symposium. Distinguished guests, participants, ladies and gentlemen, in this session, all speakers will be present a current or future challenges of public health professional, the importance of competency-based education, or we call it curriculum innovation, and also adaptation in public health, teaching, learning to address current future challenges in public health locally and also globally. Ladies and gentlemen, our first speaker is Ibu Dr. Agustin Kusumayati, MSc, PhD. She is, I already introduced her, and I think all of you know her very much, and also the speaker also know her very much. She is the chairperson of Indonesian Public Health Higher Education Network. She will be delivering the welcome speech and also will present her presentation about adaptation and innovation in public health education during disruption era. Especially for listener from Indonesia. And then after that, we have another speaker that I already informed you before. So Ibu Agustin, I will invite you to present your presentation. You have at least 20 minutes to present your presentation. Ibu Agustin, the floor is yours. Thank you.
Okay, thank you so much, Ibu Love. Let me share my screen. Ladies and gentlemen, a very good afternoon. Very warm greetings from the campus of Universitas Indonesia in Depok. Right now, we have a very big rain just now, but thank God that all of us now are in healthy situation. Ladies and gentlemen, I will share some experience, especially experience of Indonesian's public health schools during the disruptive era, we have two main factors that disrupt the situation. First, of course, the COVID-19 pandemics. But before we had COVID-19 pandemics, actually we already have the fourth industrial revolutions that also changed many of our life aspects. So these are some reasons why we should change. First of all, the fourth industrial revolutions, and then there are changes in public health problems, changes in lifestyle due to COVID-19 pandemic, and also there are significant development in public health science and technology. And of course, many of us also have new national policies. So about the impact of the fourth industrial revolutions, as you know, these fourth industrial revolutions have changed many aspects of our lives. Many jobs already disappeared, and new jobs just there because of the role of the new information and communication technology. So ICT also has changed the relationships between healthcare providers and the clients. It's also forced the development of medicine and health sciences, and it changed also the relationships between doctors, nurse, and other health care providers with the clients. So in these situations, we also have to see how public health professionals also have to change their roles in the changing situations. So in this situation, the most important capacity of all public health professionals is the capacity or the ability to adapt and to change himself or herself, because we face a very new situation that we never imagined before. So in this case, we need to adapt. We have to be agile and to change ourselves so that we can survive in the situation, in the recent situation, and we can develop ourselves. The second things is lessons that we have learned from the COVID-19 pandemic. We have known that the pandemics already make very or many new normal, new standards, new way of lives. And one of the important things of this new normal is how ICT have a very significant roles in our daily life. Such as now, we can join in this forum because we have information and communication technology that we have never imagined before. So the COVID-19 pandemic also required behavior change of the people. And we know that implementing behavior change in the community or in the institutions is not that, let's say, simple as we said. It's really need a systematic planning and needs a very detailed preparation. So the COVID-19 pandemic have teach us that the 5-level prevention is very strong one, that we need to strengthen the 5-level of preventions. That very quite old concept, but very relevant to the current situations. The experience in Indonesia, where we are quite put a lot of effort on curative, already show how without health promotions, disease preventions, and specific protections, finally our health system became chaotic. and that's very very expensive experience. And then now we focus ourselves for health promotions and also disease preventions. Finally, we can control the situations, and now all the situation are under the capacity of our health system. These are the systems that we have to develop to control the COVID-19 pandemics. How we control transmissions, strengthen health system for detect, testing, isolate, treating, and tracing. And then we have to prevent outbreak in special settings, preventive measures in places where many people goes there, control imported risks or cases, and last but not least, communication, information, and educations. The second thing that we realized based on our experience in Indonesia is how the primary healthcare should be strengthened. Because for the last decades, we to some extent do not really develop our primary healthcare. Then we can see and we can experience the pandemic. We cannot face the pandemic properly because the primary healthcare is not function well, because we more focus on curative services and the public health services is not developed. So this is also another lessons that primary healthcare has to be strengthened. In any situation, primary healthcare is very important. The question is, after we experience this pandemic, where is the position of public health professionals? We can see now that public health professionals are needed in almost many circumstances, many places, many settings, many institutions, not only in health facilities, but also in other non-health facilities, such as in schools, universities, working places, in various settings where people are gathered, for example, in the dormitory, in the public places, public transportations, in the airports, stations, country borders. Those are places where public health professionals should be available and should play their important roles to control and to prevent the transmissions of the disease. The other reasons why we have to change is the development of public health science and technology. This is a very old definition of public health. We know these definitions. And based on these definitions, we already define what we call as the 10 essential public health services. And we just see that these 10 essential public health services just changed from the old one into this new one. So this new 10 essential public health services also one of the reasons why we have to revisit our curriculum, and then why we have to see what are the competence, the learning outcomes that we need to give to the students, because they have to conduct different essential public health services once they finish their educations. Now I want to share some challenges of public health education institutions in Indonesia. The first challenge is the new policy in higher educations, what we call as emancipated learning. In this policy, the students may have the rights to have maximal 3 semesters out of 8 semester to join any activities outside the study programs. They can do, for example, student mobility, internship, doing teaching at the schools, for example, doing research, independent project, community engagement, and also entrepreneurial activities and other social activities in the community. So it is really encouraged by the Ministry of Education now to include these activities in our curriculum so that our students may have the opportunity to learn another subject besides their main subject. So these are the future outlook of educations. Due to new normal, we have to apply dual modes in teaching and learning. We have to develop online mobility program. We have to adapt a new academic policy, push e-governance, ensuring budget sufficiency and efficiency. Budget is one of big issue since during this pandemic, the income of many universities reduced quite significantly. And then we have to develop a partnership with many partners for impactful Tridharma. Tridharma is teaching, learning, and then research and community engagements. While Emancipated Campus need us to update our curriculum, also update our academic policy, strengthen student-centered active learning, strengthen internship and community engagement, and should be supported by strengthened and helix partnerships and also strengthened faculty-led collaborative programs. For research, we are now should refocus our research and innovations into these 5 main themes: health and well-beings, energy and materials, innovative and connected society, government and security, sustainability, and of the earth and the environment. For the community engagement, we have to focus first, of course, response to the pandemic, to the COVID-19 pandemic, can be through research, social actions, policy brief. We have to focus on community service engagement to achieve SDGs, and we have to mobilize resources to support our community engagements programs. We did, this is an example of Universitas Indonesia. We did a tracer study, and then the student expressed their hopes. What should be strengthened? So they said the first to be strengthened is entrepreneurial skills. The second one is opening more opportunities on internships and community services or engagement. They want to have more English proficiency. Students also need more exposure to international experiences. And last but not least, they want upgraded qualifications in multidisciplinary competencies, global issues, research skills, and negotiation skills. The challenge is now many of institutions in Indonesia face this challenge that we have problems in ICT infrastructure, the learning ecosystem, big data management. We have also problems with the faculty readiness, especially those from the older generations, effective governance and investment, linking and matching the programs, and the reciprocity. So to do this, these are the main 3 strategies. First, we have to strengthen the learning resources by providing more online resources, MOOCs, massive open online courses, micro-credential programs, and then capacity building for all of us to make us more familiar with the technology used to support teaching and learning, and then to improve infrastructure. Among the infrastructure that we have to improve, for example, is virtual and remote laboratory, virtual help desk, and of course, integrated digital learning environment, an ecosystem where there are many tools and components available there that can be used by the students, by the staff, so they can communicate, they can set up classes. So this kind of learning environment should be developed in every institution. So these are some strategic innovation that important for us to be considered. First one, when we are developing our new curriculum, please we consider to build this critical skill that needed by the students to be able to survive in this disruptive era. These are all the critical skills that are needed for everyone to be able to survive in every situation. The second one, we have to re-emphasize the core public health competence. These are the 8 core public health competence, starting from analysis and assessment, policy development and program planning, communication, cultural competency, public health science, community development, management and financial planning, and last but not least, system thinking, leadership, and entrepreneurship. The next is ensure the capability that we ensure to build the capability of our students to perform primary healthcare. This is very important because the pillar of primary healthcare is really beyond health. For example, community participation, intersectoral coordination, using appropriate technology and other support mechanism. So we have to ensure that our students that once become our graduates have the capability to perform this primary health care. And then the next issue is to apply outcome-based educations, that we focus on student learning. We focus on what students should get and how are we going to allow the student to get the outcome that they have to get. This is what we call as outcome-based educations. Of course, adjust teaching and learning environment and methods. Put more attention to interprofessional education to build interprofessional collaboration skills. Apply student-centered active learning. Establish learning ecosystem to support. And then apply new standard to ensure safety and health. Especially, we have to modify and to redesign field work, so that our students can be maintained safe and healthy during the field work. Last but not least, use ICT, of course, information and communication technology. And don't forget to consider linking and matching with the prospective industry or users of our graduates. Ladies and gentlemen, this is what I can share for now. So I really expect that all of us will be at the front of ensuring the world sustainability during the COVID-19 pandemic. Thank you so much. I return back the screen to Ibu Lofi. Thank you.
Yeah, thank you, Ibu Agustin, for a remarkable speech. Now, I'm also honored to invite our second speaker, Professor Dr. Yawen Betty Chu. She is a professor and director of Master Program in Global Health and Development from College of Public Health, Taipei Medical University. She has teaching and research interests including health policy, health security, international health organization, foreign medical aid, and evidence-based practice. Prior to becoming a professor, Dr. Chu was a government research from a variety of government agency in Taiwan. She will present about global health security, governance, and education, the enhancing role of university. Mrs. Betty Chu, the floor is yours.
Thank you. Thank you for the kind introduction, and thank you for the invitation. Since Dr. Agustin is a long-term friend of mine and she's the master of public health education, I do admire her talk she just provided. And I think she already provided a very comprehensive and thorough explanation of the public health education and challenges. So given the show notice I have, so I would like to use COVID-19 as an example to together with you explore what's the missing parts in the current public health education. So just like you can see that I decided to talk about global health security governance today because global health security is a rare discussed area and which is also very important. It's not just a single discipline, but also a multiple or multidisciplinary area. So in the end of that talk, I will be also touching upon the defensive role of universities. All right. My another head is Taiwan Regional Director of APAC. And you can see my email in the PPT. Sorry, we have some technical problem now. Please allow me to use 30 seconds to fix it. Okay, while my research assistant is fixing the computer, then me just try to explain some of the background. Okay, in the human history, there are a lot of many kinds of microorganisms that affected human beings, like plagues, cholera, yellow fever, HIV/AIDS, and just within these recent 100 years, at least 5 flu affected us, like Spanish flu, Russian flu, Asian flu, Hong Kong flu, and swine flu. And within these 2 recent decades, SARS, MERS, Ebola are all very famous. And the current COVID-19 is a game changer. The death number in the whole world is reaching nearly 5 million and still going up. Can you hear me? Hello? Can you still hear me?
Yeah, sure. We can hear you clearly. Yeah.
Sorry about the screen. We are trying to fix it. Okay. So let's move on to page 4. Page 4, thank you. All right. So just like I mentioned, COVID-19 is not the first one and it won't be the last one. So what can we do? 73 years ago, WHO was established. Then it announced the very first version of international health regulations in 1951. And the IHR hasn't changed much until the recent for the 2003 SARS COVID, and then officially implemented in 2007, which is 40 years ago. But do we live happily ever after? From the screen, you can see that actually IHR was invented to together protect global health security with 3 pillars: to control risks, to respond properly, and to do specific. But on the ground of all these actions, it takes global partnership. Okay, if you look at the number now, very quickly, the deaths per million in the whole world is 625. In Indonesia, it's 517. And then in Taiwan, the average is 35 deaths per 1 million population. So we are happy that the COVID-19 is still under control in Taiwan properly. And the secret I want to share today is how did we keep 0 cases in nearly 300 days since the outbreak last January. And you can see there is a peak just happened in June and July this year. It's a tough one, but we are managing it and we are doing fine. So here are the summary of our 6 key factors. The 1 is SARS experience, and the 2 is high alert and timely response. 3, risk communication and information transparency. 4, proper resource allocation and supply chain. Number 5 is transmission prevention using digital facing tracking system. And 6, Taiwan is citizens. They follow the guidance very well. This is the picture 2003 during the SARS outbreak. And you can see the health personnel, they panicked. They were so panicked because of sudden lockdown of the Taipei and this awful hospital. And they crying out saying that we want isolation by areas. We don't want to wait and die. And this picture was so shocking to the whole Taiwanese society. And during that outbreak of SARS, nearly one third of deaths cases are health personnel, which means our border patrol didn't function well back in 2000. And the main outbreak happened in major big hospitals. So since then, we have a lot of reform, including regulatory review and organization adjustment. We amended communicable disease control act at least 3 times since then, and restructured Ministry of Health and Taiwan CDC. So the National Health Command Center, NHCC, was established. And since then, Taiwan government recruit and train specialists in a very serious way. That's why we can establish the Central Academic Command Center just within 3 weeks after something about community. And our CCC is led by a team of experts. They work with the health minister and more than 10 public sectors together. All the important decisions based on this prevention expertise. And they will continuously adjust test definitions and criteria for case reporting and revises clinical and medical treatment recommendations. Even the recent vaccination for immunization plan are strongly suggested by them based on current evidence. And of course, we can help to mention about this paper again. This is published by Chinese CDC, and in the paper they published last year, January 29th, they say they already found human-to-human transmission since December of 2019. So our thought is if they have time to accumulate and count the cases and have time to write the papers, manuscript to submit, be published, why don't they have the time to inform the whole world that something serious was already happened? And in Taiwan, we are very lucky. We can read Chinese. So here I would like to echo what Dr. Agustin just said. English proficiency or bilingual ability, even trilingual ability are quite important. Here we catch some emergency notification issued by China Wuhan Health Community, and they say they found typical pneumonia cases. But this notification is only for China inside. And we are lucky to found this in some social media. So we are able to do timely response since January last year. We banned the entry of Chinese nationals from Hubei and extended to Hong Kong and Macau within 2 months. And keep monitoring the conditional situation. Just travel notice. And the travelers arriving from level 3 countries are subject to things until now. So just like I mentioned, according to IHR, when we catch this from the social media, oh, suddenly typical pneumonia cases like SARS, the nerve of our Taiwan CDC just hit, and we know there's something wrong. And according to IHR, something like SARS is to be reported immediately to the WHO. So we stick with the rule. And on board quarantine of passengers on direct flights from Wuhan started. And this is to show that Taiwanese citizens, even Taiwanese citizens on the charter flight arriving at Taiwan has to be fully put everything aside. And we guard every point of entry, including on the sea. This is a picture taken on the cruise. Public health authorities or personnel, they board start various test trips and treat passengers on that cruise. And our third tip is risk communication is very, very important because we don't want those people to be in panic. And so our CDC posts daily first news every day since January last year. Then it stands until now. And we provided all the official line on Facebook to give transparent and correct information to all the relevant moving forwards and enhance the capacity for 1922 campaign for disease report. And this is the so-called infodemics management and fit to the so-called whole approach to provide credible, accurate, and timely information to combat fake news. The fake news is just like disease or virus, they spread so. And this is a picture of CCC. In the middle, the gentleman is our health minister, also commander of CCC. He hosts every conference by himself every day since last year. In order to keep information transparency, our national health insurance database is linked to the immigration agency. We have the work platform added designated facilities for to protect our frontline hospital workers. They can immediately aware of suspected infections based on the travel history. And we also have a national health insurance medic cloud system to display the notice and testing. We also have a ration mass distribution system to help proper resource allocation. So all the citizens, they can bring their national health insurance, the NHI IC card, to purchase face masks at over 6,000 contract pharmacies and over 10,000 convenience stores. And all the staff and location of pharmacy are all released government openly combined with government openly example PP in the related by manufacturing. More than 100 million purchased masks on services. And this is a picture to show that people use additional IC card to purchase face masks at pharmacies. And the first tip is transmission information. Home quarantine monitoring system help us a lot. People in home isolation are required to allow their mobile phone location to be monitored. If a phone or has no signal, warning will be sent to that person and the related agencies, including local police. So the people in home isolation or quarantine, if they don't obey these rules, can be up to 35,000 USD. This holds 500 million. Indonesia, 500 million. It's a huge number. So we have to give the credit to the companies because they really follow the guidance very well. They learn and remember the experience themselves. So most people understand the importance of basic public health measures like wearing masks, maintaining social distance, washing hands. And this kind of new lifestyle of academic innovation are well accepted and adopted and implemented by Taiwanese learners, including the environments. And we call it a whole society approach because we understand no one is safe until everyone is safe. So this is just a picture to show that the global public practice social distance everywhere. When they are waiting for the public transportation, school kids eating lunch, waiting in the queue for takeaway, or marking for social distancing, or even eating at the convenience stores. And I would like to quote from a very important review report led by two respectable ladies, including the former president of Liberia, who is also a Nobel Peace Laureate, Ellen Johnson Sirleaf. In their report, they conclude prioritizing health or prioritizing the economy could be a force victim. Economic outcomes be better if economies were strict public health control measures that be implemented. And the same pattern appears with more strict public health measures being followed by strong economic recoveries. I would like to say no health, no health. In Taiwan, we still need to protect health first in order to protect health. And we still, we once holding two numbers in the world from the bottom. This is a issued by Competence. The two numbers Taiwan are holding are, we have the lowest COVID deaths per million, and also the lowest GDP loss. So if we look at more response review from other panel or reviewers, they all summarize that key success factors to survive from COVID-19, whole of governments and whole society approach, and epidemic management. Also, health literacy and past experience are quite big. So another factors, Taiwan is we have National Health Insurance System instituted in 1990. It's a full digitalization of medical information system, covering nearly 100% of the population and 93% of the health facilities. It's very high satisfaction rate. So this kind of digital technology plus infrastructure, we link the database together across the different public sectors, really help us a lot. Just like Dr. Atkinson said, this is a digital overview. And here are two another information to help explain this kind of theory. The GPHIS name very long established platinum size for their reliability. They use data algorithms plus human analysts. And these two networks that detect several disease outbreaks, including Zika, MERS, and flu, before official news. And another example is ISR, text mining of social media pages. Now, the IHR already recommend everyone to use third sources except the origin country. And Taiwan uses similar systems and methods. on China's news and social media. It's how we found the full-time motivation. And we are happy to say that after 20 years of long fight, finally our company passed the public health spatial business act last June. And we believe it's the first in Asia. And we are very happy that Taiwan finally really wants to invest more on public health education and the spatial business. And another three examples is our former Vice President, current Vice President of Taiwan, and the former Vice Premier. These three gentlemen, they all have a very good public health education background. And we are very fortunate to have them in Central Cabinet when we started the fight with COVID-19. They play very major roles in this long fight. So if we look back to see what will be the future for country level advice, is that we learn from the past experience and we have to establish strong and reliable leadership and stick to strict border control measures. So, of innovative like ICT-based surveillance and smart custody. For the global level, we like to point it out that improvement in revision related to some must, especially penalty costs has to be taken. And the reform WHO, including the public and leadership and inviting the beloved to share best practices are our expectation. If WHO and UN can say they provide why accept Taiwan, we can provide and contribute more to the global health, security, and governance. So once again, investment in public education and workforce is a trend. So the role of universities, not just education, but also provide awareness and quality research to raise awareness and engagement for policymakers and justice systems. So we can provide and will be effective. And my final message here is international cooperation and global partnership are very important. So once again, I'm very delighted to be invited to share some Taiwan perspective with you this afternoon. And then say, let the collaboration continue. Very much. Thank you.
Okay, thank you very much, Dr. Betty Chu, for informative and insightful presentation. I also want to ask some question for you, but I think all of the participants also want to ask some question, but we already have one question, but we will do it ask and question later after all of the speaker present. So now I also honored to invite our third speaker is Dr. Shafi Buyan, PhD, MPH, MBA, MBBA, FRS, PH. He is an internationally recognized leader in global health and education initiative with diverse experience in both developed and developing countries. In Toronto, Dr. Buyan is co-founder of the innovative internationally trained medical doctor bridging program. He is an assistant professor at the University of Toronto Dalla Lana School of Public Health and also co-creator of MSCH pilot program at the LSPH. Dr. Buyan held position as adjunct professor at Faculty of Community Services at Ryerson University, Canada, and visiting professor at Bangladesh University of Health Science. Wow, I say good evening, not good afternoon to Dr. Safi. Good evening, Dr. Safi.
Yes.
Yeah.
Good morning from Toronto. Can you see my screen?
Yeah, sure. You have 20
Excellent.
minutes to present your presentation. Thank you.
Okay, thank you. Actually, I really appreciate you and my friend, Dr. Augustine, and the previous presenter. Actually, yeah, wow, this is almost 5 o'clock in the morning in Toronto, and wake up at 3 o'clock to see how exciting it is. I think I would like to emphasize few things because my friend Dr. Augustine and Dr. Ya Win already detailed very informative, impressive presentation they made, and something touched my heart. And I think if I start with the topic Dr. Ya Win mentioned, public health education matters, leadership matters to me. And also she mentioned very rightly, core competency is very required to address the era of pandemics and so on, to ensure human security. And my friend, Dr. Augustine, emphasized already how important it is to prepare our students' body as an entrepreneurial skill and international experience and so on, by making sure that we address student first service at the university level, and also importance of interprofessional collaboration. So all is my favorite topic. So everything has been said, but I would like to just, by the interest of time, and I would like to, you can see, I'm from Toronto. I'm the professor at the University of Toronto and a social behavioral health science and clinical public health. So I also outgoing chair of Canadian Coalition for Global Health Educational Research. And I today would like to emphasize 3 or 4 things mostly, which actually very important, you can see in the recent viewpoint, as my friend asked me to talk about current and future challenges, public professionals, or what kind of competency needed to address and respond current and future challenges in public health. She also mentioned the answer. The answer is innovation, adaptation. And you know, Albert Einstein mentioned that in the middle of any crisis, opportunity lies. So I think this COVID era, not putting us in a challenge, also give us to learn together. Number 1 is collaboration. Number 2 is adaptation. These 2 is we learn from the COVID. I think using this concept, we can solve many problems, even though is an issue, but let's focus on the solution. That means how we can make an impact. Most importantly, when you talk about health equity, universal health coverage, Dr. Ya Wen nicely mentioned, and talk about social accountability, well-being, or prevention of disease or prevention of illness is very important aspect of our recent eras, or after COVID or during COVID era. So we need to ensure that we must follow the current challenges, which is important aspect is social accountability. So by ensuring urban or universal healthcare, it is already obvious that equity is the front and center, and that's what we need to think about. And this is no wonder we know these things. So how important it is to make universal access to the healthcare, give the equal chance to the people, and this only matter by policymaker, by societal or the cultural respectful services. This need to be addressed, and this is the high time now. COVID exposed our health system, how fragile, how broken they are. So if we are not prepared previously, now we need to prepare. Otherwise, consequences we already observed in recent days. So in terms of universal coverage, we all know the discrimination is one of the issues, despite of we know that inequities in all stage. So to cover that up, we need to address the and discrimination and stigma. We need to ensure the access of whole package service of the community people with quality, and we need to sustain enough budget need to be placed, system thinking need to be placed, and it should be affordable because according to the universal health coverage, we know WHO, World Bank in 2014, they make a clear framework that all people need to get health services with quality, high quality, and they should not have any financial hardship. So there is a spectrum of services: is promotion, is protection, treatment, rehabilitation, and so on. So we must consider to provide our health services utilizing this concept. But how easy it is, it's easy to say, but maybe difficult to practice. So if we think we can do it, we can do it. Of course, we need innovation in all way. If innovation is from the high-ranking people, then maybe we lose the understanding of local context. It may not so effective as we thought. But if innovation come from start or emerge as a result of system thinking from the bottom up, in especially low middle income countries, that may be a real innovation, that may be one of the way to sustain in our healthcare system. And having said that, we need to talk about education. So when you talk about education in many countries in Southeast Asia, including in G7 countries, we still struggling to understand which way we should go. Many health education system is like kind of disease and treatment oriented things, but we need to build the health education and not only creating a doctor. We should create a health professionals to have those who have a public health competence, and we should understand what is the competence and competency. So that is very important to remember. Competence, it can be like a assemble of building blocks, and competence is the multi-dimensional and is a dynamic. It can change over time, experience, and so on. So we need to think about this, and we need to give this momentum at the post-secondary or graduate education or postgraduate education level. And so many times we talk about social accountability. In the first of my slide, I talk about this, and also previous speaker, they also mentioned interprofessional. They also mentioned educational, institutional next responsibility, what to do. I think education, research, service, this is the key package of any university system, so that we work together, we collaborate together to find out the solution, and we should be part of the solution. We should not be part of the problem. So, and what we need to solve, we need to solve our health system gap. Our mission is to strengthen the health system, which is now broken. As for example, many countries, even Canada, is struggling. Elderly care, palliative care, and mental health, and we need to solve these issues. We can do many ways, but we need to ensure our system thinking, so that we need to improve our next generation learner, more and more research and innovation, because innovation is the highway of development. But we need to incorporate in our curriculum. But how to do that is maybe challenge, given the current infrastructure or current academic curriculum. So several times I listened that we need to find a way, like Dr. Augustine mentioned, in Indonesia, students are now allowed to go three semester or three or four courses out of 8 courses time to spend in the community. So that is the right thing to do. In Canada, we call it experiential learning. So which is very powerful, not only theory based, but they should be engaged in the community, what they're observing, which is not put in the textbook yet. So they should show firsthand to find the problem and how to solve it by utilizing primary healthcare mechanism. And they see something, they find and feel, they analyze, they make a plan and act, and they can change their plan. That's where they can be more confident and more evidence-based practice. That may be one of the priority. We need to go and we need to move forward.
Dr. Sami, sorry I interrupt you. Would you mind to slideshow your PowerPoint?
Sorry?
Could you please slideshow your PowerPoint? Yeah, because some of the participants cannot see clearly.
Okay.
Yeah.
Can you see now?
Yeah, but it's more smaller. We just see the slideshow. Yeah.
Can you see it? I don't know.
Full slide. Can you slideshow like before? But I think you should. Yeah. Some of them can see well.
I think they should pick.
Yeah, that's better, I think.
Okay. Yeah. So if what I was talking about the experiential learning, now I would just want to continue. In the tradition, we have a classroom and we speak, instructors speak, and students listen, and they go home. It's just one way to teach, and we need to come out one innovation which is a community-based or work-oriented experiential learning. So students can go out and they focus the research project, independent project, community services, what Dr. Augustine mentioned, internship and co-op education, which may better. They learn from the community, they learn from the peer, they learn from the ground, and then they can find the solution as an innovative way as a young professionals. We know that experiential learning is very important. Why? The only source of knowledge is experience, Einstein mentioned. If you see this pictogram that you can see, the lecture tradition we make in the class, only 5% student can retain that knowledge. And if they read, the 10% they can retain. If they demonstrate by themselves, they're only 30%. If they discuss with the group, maybe 50%. But when they practice, 95%, 75%. When they teach and others in the community, and then they remember, or they can successful at 90%. So you can see there is no statistic required to understand this concept is the right things to make a priority in university settings. And already Dr. Augustine touched up these things. I just want to say that it's important to find the data, analyze the data, understand the situation, and make a policy advocacy and practice and change the policy. Or other way we can do it, policy into practice or practice into policy. So this is the job public health professional always make the priority. And we need to practice more and more so that our next generation young professionals, they can practice in this context. Also, there is a many misunderstanding in communication about the public health. Dr. Augustine rightly mentioned the traditional definition of public health. So in many countries in Southeast Asia may think only doctors can be public health professional, which is not true. Anybody interested in the health and well-being multidisciplinary professional we prefer to join, maybe the social science, maybe international affairs, maybe medicine, law. These people should come forward because we really need interprofessional collaboration to understand who we are, what is our core issue, and how we can serve with the cultural respect, and how we can address the people who are behind. We need to focus not only disease-oriented service, we need to focus of well-being and preventive strategy. And we need to address diversity principle in all levels, even in the university education, even in the healthcare services. And this is very important nowadays in public health sector. And I think this is one of the key things in public health education. We need to emphasize, we need to promote the inter and multidisciplinary study and to involve different stakeholders. And many young professionals, they send email to me from different countries in Southeast Asia, what job we can find if we study public health. And it's a bunch of things we can think about public health professionals, their job, which is, this is a very few list, but we need to encourage young professionals so to come and join us because why? We need to create a health system where we need a leader who can redesign, rethink our curriculum, rethink our system, so that the graduates we produce, they will change the institution, and the changed institution will create the bold ethical leader. As I start with the two things from public health education and the leadership, and leadership matters. That's why I think only adaptation in new health, public health education is required, because it will improve creating a new and timely leadership who can redesign public health education. Once we adopt this change, and learner will learn things, and it will be just continue emerging and producing bold ethical leadership, and they can make future change, so we don't have to wait. Remember, education cannot wait. If we educate, if we continue to support our young professionals, they will make a change, and it's only possible. We need to go to our community, as Dr. James Yan, maybe he is from Taiwan. He said, this is the note I got my professor when I got graduate in 2005 in PhD in human sciences, international cooperation. Go to the people, live among them, learn from them, start with what they have of the best leaders. When the task is accomplished, the people all remark, we have done it ourselves. And that's exactly Taiwan or Indonesia, they are doing. They're learning from the local experience and together with the community. And then we can see and we can congratulate Taiwan, their achievement in public health control, where in many developed countries also struggling. I think this is it. I would like to thank the organizer, the committee, my friend, and all of you to giving me the chance to share with you. If any questions, so I'll be happy to answer.
Wow. Yeah, thank you, Mr. Safi, for interesting presentation. I have a burning question for you, and I think some of the participants also have a burning question to you, but we have to hold the Q&A. We have the last but not least, we have the last speaker, but also Ibu Agustin said he is the youngest speakers in this room, I think. I also want to introduce him. He's Mr. Calvin S. de Los Reyes, PhD. He's a senior lecturer, graduated program in Health Policy Studies from Department of Behavior Science, College of Art and Science in University of the Philippines, Manila. He also senior lecturer, special appointment, Department of Global Health, School of Health Science, Faculty of Medicine in the University of the Ryukyus, Okinawa, Japan. And now he is joined with us from Okinawa, Japan. Is that correct, Dr. Calvin?
Yes.
Yeah, okay.
So, konbanwa to everyone. Yeah. Okay. So, may I start?
Yeah, sure, you have 20 minutes.
Okay. Thank you very much for that kind introduction. Yes. With that, no, that would be my lead in as being the youngest member of this group. No, I must admit that I have several disclaimers for my presentation. But anyway, what I'm going to present is actually a group effort, no, with me consulting with my colleagues from the university. Let me share my slide. I'm sorry. There you go. So my presentation, I want to thank, of course, the AIPPKMI and the Asia Pacific Academic Consortium for Public Health for inviting me for today's event. No, especially we cannot really say no to Dr. Agustin Kusumayati when you are asked to make a presentation. I am presenting on behalf of my colleagues from the graduate program in Health Policy Studies. Professor Marilyn E. Crisostomo, our chair, Professor Lofred Hernandez, and the former dean of the College of Arts and Sciences, and a colleague, Dr. Reynaldo Imperial. Let me begin. The Philippines last Tuesday logged about 4,000 new COVID-19 cases as local tourist destination eased restriction for travelers. The day's tally brought active cases to almost 54,000, with about 8,500 new recoveries and 135 new deaths reported. Overall, a total of about 2.8 million COVID-19 cases have been reported since the pandemic began in March 2020, of which 2.7 million have, and 42,000 actually died. The fight against the threat to COVID-19 pandemic suffered profound impacts on all sectors. And this have resulted in the widespread disruption, as we already know and have presented earlier by my colleagues presenting today, travel restrictions, economic effects on economic recessions, sometimes political conflicts in the US, racism, and more so on misinformation and controversies, as well as the closure of schools. And the educational sector indeed is one of the most affected. The health, social, and economic crisis of COVID-19 pandemic have thrown into sharp relief the disruptive forces acting on the global higher education sector. As COVID-19 pandemic is still very existent today, measures of living up to the new normal is essential. We need to live with the virus since it is constantly evolving and infecting most of us. So here, I wanted to present the immediate challenges that we want to confront, no, and what we have actually experienced. I believe this is not unique in the Philippines, but it's common worldwide or globally. So there was institutional disruption, of course. Staff and students were affected by COVID-19, so that's one of the things that we have to deal with. No, they might have been affected by COVID-19 outside the schools, but some of the staff could have had the infection while they are working in their respective higher educational institutions. No, there were student displacement and at times loss of vital campus services and support to the students. There's also the technical debt. Even advanced, wealthy countries, no, find themselves hampered by the use of outdated technological platforms that are readily available, and more so for those who are coming from low-income countries, no, like the Philippines. Maintaining instructional operations, including courseworks, exams, and awarding of degrees. There's a much needed review and modification of assessment modalities, and maintaining or closing operations, including on-campus laboratories and facilities, fieldwork, conferences, and external research collaborations are something that we have to think about. So there's a curtailing of international mobility, including logistical implications for repatriation of at times locally international students, no, on their housings, some of the staff and faculty furloughs, student loans, no, as well, and of course we cannot discount the equity implications, no, in academic, social, financial, and physical among those who are coming from low income, at-risk students, no, potentially those with COVID-19 health vulnerabilities. As mentioned earlier by Dr. Agustin, Professor Agustin, there is a need to adapt and change as we experience the pandemic. No? So I'm happy that she was able to already emphasize it earlier. No? So I won't be explaining it anymore. So I wanted to start off again with how did the higher educational institutions respond to COVID-19 in my country. No? Actually, in the onset, no, in 2020, no, the Philippines didn't do any better because they viewed COVID-19 as in the very beginning stages as a health issue alone. No, but later on, of course, we all realized that the impact of the pandemic cuts across all agencies. No, so the Commission on Higher Education, no, at first, gave some guidelines for the prevention, control, and mitigation of the spread of the, as you can see here, it's the 2019 nCoV ARD, or acute respiratory disease, no, as a reaction. No? Eventually, the Commission on Higher Education, it was mobilized by the IATF, no, the interagency task force no, sat down. The Commission on Higher Education became a consultative body, no, with the IATF, and eventually the CHED organized the higher education institutions on the ground. The key is to actually act fast, no, and making sure that the whole of nation approach was used. But they also mobilized capacity and experience of the universities on the ground and adopted flexible learning approaches to ensure that learning continues there. The aim was to provide students and faculty members the needed information and support amidst the novel coronavirus, as well as assist in several activities, no? Especially since the academe was asked to produce researches, materials to help mitigate the effect of COVID-19 and devise creative ways to help the government manage the pandemic. So it's more of a Filipino ingenuity. We call it bayanihan, the spirit, no, in Filipino, like helping each other, cooperating, no, in the occasion of the dwindling supplies in public health, no. So as you can see here, there are test kits produced, no, which are 6 times cheaper than its imported counterparts. Several higher tertiary colleges and state universities and colleges, rather, SUCs, have produced their own face masks and shields, with some of them even reusable. There are protective suits also developed, no, as well as local versions of ethyl alcohol and sanitizers and aerosol boxes coming from the engineering groups. In addition, partnerships with state universities and colleges and local government units use their facilities, no, for quarantine or even as isolation units. So, how did the university? What happened is many universities and colleges have, in the space of days or weeks, moved their operations online. No? Below are some of the major actions by each institutions. No? So, acting on the short term, using video conferencing such as Zoom, before it was even Skype, no, and creating help desks, as well as a medium term, strengthening policies, no, institutional capacities were done. In addition, mobilizing widely used mobile first and readily available scalable resources, no, as well as setting up a one-stop shop of resources and help desk, no, for administration, faculty, and students, as well as curating existing content and gather feedbacks on usefulness of the rollouts. And also communicated with the faculty members, students, and other stakeholders, providing comfort and guidance in this very time. So, as I've mentioned earlier, no, there was a move from the Commission on Higher Education for flexible learning, no. Here, flexible learning is defined as a pedagogical approach following flexibility of time, place, and audience, including but not solely focused on the use of technology, although it commonly uses the delivery methods of distance education in facilities of education technology. This may vary depending on the levels of technology, availability of devices, internet connectivity, and level of digital literacy and approaches. The higher educational institutions were tasked to identify the best learning approach based on the health situation of their corresponding settings. So it included some consultation with local governments, assessment of capabilities of faculty members, and also their students, and also the technology available, so connection and gadgets, etc. Many of the universities adopted an online option, with some offering a mix of offline options. So of course, there are some areas where there's a poor connection and lack of technology, thus offline. They have no choice but do offline. But teaching was constantly adjusted and improved to make sure that learning does not stop during the pandemic. And I wanted to emphasize that, no? As mentioned, there was a transition from traditional to flexible learning, which included the revision of curriculum of various programs to cater to the new methods of teaching and learning. There were funding coming from the Commission on Higher Education for content development, here amounting to 200 million pesos or 4 million US dollars. And having in order for us to have a learning management system for the higher education institutions. There were realignments in budget to meet the flexible learning needs of the students and faculty. And some were lucky to have their own laptops and better connectivity, especially some of the teachers from the SUCs, and address problem as they come out during the shift traditional to flexible learning. And of course, there are some training programs for faculty members in order for them to do the flexible learning. Yeah. Okay. So we were wondering, the curricula, no? The question remains, what curriculum should teachers use for remote learning during the COVID-19 crisis? So the response will vary, of course, by jurisdiction. No? So some have prescriptive national curricula, whereas others give wide discretion to teachers to choose program content. But the general advice for teachers is to keep two objectives in mind. So what is important to continue to orient students' learning to the classroom curriculum and the assessment or examinations for which they were preparing. It is also essential to maintain the students' interest in learning by giving them varied assignments, not least perhaps by work that sets the present COVID-19 crisis in a wider global and historical context. Some of the schools are encouraging students to engage with the crisis by preparing hampers of food, supplies for vulnerable families, or even writing letters to elderly in care homes. So there, no? For such enrichment, teachers can draw on the abundance of high-quality learning materials now freely available online, some from open educational resources, and even from my university, the library had been really have been providing us with opportunities to do a lot of researches online. No, there you go. Okay. Thus, we have to recognize the need for just-in-time support in the day-to-day adaptation of tertiary education delivery to the impact of the pandemic. The following information depicts a series of consideration and actions institutions should follow as they work through the immediate and long-term adaptation to the changed environment for tertiary education. So we have to ensure that we train instructors on how to teach remotely, tailoring to the training to allow each academic staff member to define their own plan for content, goals, and learning assessment within the new modality. Seek and adopt existing online remote platforms for creation of new online resources after traditional in-person instruction is not visible. We have to survey students on their capacity to engage in remote learning, as well as coach and support students on how to learn remotely. Provide hardware to students and instructors where feasible, it's not always the case, and determine both an institutional policy for assessing current term students' performance, as well as the teachers' assessments and course evaluations. There's also a need to review and determine graduation requirements, as well as assess adequacy of provision of financial and material support for at-risk students and institutions. And finally, develop and implement programs to keep at-risk students engaged, including uh, through perhaps point persons and customized work programs or schedules. Of course, research is still relevant, no, even during the pandemic, no, and well, some of the things that were actually done was to support the academic staff to transition where possible their research to remote platforms of our context, provide support to allow research fellows and staff to maintain access to network materials, technology, and any virtual laboratories and simulations, consider shared maintenance programs across institutions and centers for equipment and facilities, create plans for animal and human subjects for safest and most humane options in contexts where their safety may be impossible to ensure and maintain lists of essential research spaces and materials to develop a rapid response and minimal maintenance plan in case of emergency, and consider for conducting experiments and research online, virtual reality. So, um, recently in January 2021, no, as mentioned also earlier by Dr. Shafi, no, there is a need for experiential learning, especially those who are coming from the following, no. So there is already an approved guideline for the gradual resumption of limited face-to-face classes, which began in January 2021 among those taking Doctor of Medicine, BS Nursing, Medical Technology, Midwifery, and other allied health courses. Yeah, given that the medical and allied health programs are in MGCQ areas, no, and select HEIs with students serving in COVID-19 hospitals. And of course, the universities are retributed to meet the guidelines of the IATF, and the students should be 20 years and up. However, this is non-mandatory. Students who do not prefer attending will be provided alternatives, close, and hopefully this would be close to the learning experiences for the face-to-face section. And once the schools are reopened, of course, we have to have the following as a basic checklist, no, minimum health standard when the schools are reopened, hand hygiene, respiratory etiquette, no, physical distancing, use of masks in schools, environmental cleaning and ventilation, and procedures for isolation of people who might develop or have symptoms of COVID-19. Of course, in conducting face-to-face classes must be planned following national and international guidelines to ensure that students will be safe or at least mitigate the effects of COVID-19 there. Of course, with the face-to-face classes, it has policy implications. For one, of course, we want to ensure that the hands-on training in manpower in hospitals, allowing limited face-to-face classes would, of course, improve the much-needed experiential learning of the students. But in addition to that, we are assured that there are additional health workers who could assist during the pandemic, especially in those institutions with their own health facilities. In addition, the HEIs, some of them are actually serving as vaccination centers. So this is a good venue for vaccination because they are already retrofitted, and safe, so it's in May of this earlier in May, it started with 34 higher educational institutions. Now they are increasing in number. And recently, the clinical rotation of clinical clerks and postgraduate medical interns will continue regardless of community quarantine status. This was posted last month, September 17, 2021, ensuring that face-to-face rotations. Given that the clinical clerks and postgraduate medical interns, as an example, already have completed their vaccine schedule. So how do we ensure safety again? Of course, vaccine prioritization of higher educational frontliners. This includes not only the clinical instructors, but also their teachers, the students, or even the support staff. Who are required to report and must be assured of their protection so they can confidently provide essential services to more than 3 million students in higher educational institutions there. I wanted to raise, as I wind down with my presentation, no, some of the points, no, raised by the Dean of the College of Public Health, no, Dean Vicente Belisario, during the public health education and new normal towards achieving the SDGs around the table discussion with Philippine HEIs on May 27 of this year. So there's a need for enhanced academic programs, research and innovation because, well, one, there was a disruption in delivery of health services. And note that during the pandemic, a lot of the services, EPI, expanded program immunization for children, maternal and child health, they were unable to continue or to visit the health centers, some mass interventions for, let's say, deworming, etc., were disrupted. And of course, the centralized health system with varying levels of capacity to spearhead delivery of public health services. In some areas, it may be good, because of the decentralized nature, and some may not be as good, depending on locality. And with this, there could be delays in reaching the targeted United Nations Sustainable Development Goals. And in time of the pandemic and new normal, there's a need for more than business as usual, but need for catching up. And as mentioned earlier, innovation, teaching, training, research, and even public service. And also, we have to combat misinformation, the fake news. We need stronger health communication, sharing facts versus policy, and more on what works and less on what doesn't. In addition, in the Philippines, there was a convention of public health schools in also in February of this year, and it's one of the first meetings. Actually, it's the first meeting among public health institutions, higher educational institution, and it was identified that there was a lack of HEIs with undergraduate and graduate public health programs in many regions. There's a need for a clearer picture of the state of public health education in the Philippines, lack of oversight of the Commission on Higher Education, and lack of regulations of PRC, and lack of accreditation for professional public health society. So there's an importance of public health and public health managers in time of COVID-19, and other major public health concerns were actually sidelined. And one of the questions raised earlier was competency, and there's a need to look in public health, competency needs in public health on the systematic approach, considering the building blocks to guide public health education for human resources for health development, and need to quantify their needs further in public health. In a survey, HEI survey on coping with the new normal, similarities with response, good practices, probably shaping teaching learning in the new normal, commitment and dedication to public health education is even amidst trying times. And there is also a move to align undergraduate health science courses with primary care, and need for short courses in epidemiology in compliance with the universal healthcare requirements. And continuing need for good data in public health to help direct policy formulation, response, and action, and appreciation for attendance and participation in the first forum of the HEIs of public health which allowed the start of conversation, potentials for sharing of learnings, good practices, possible even continuing information exchange, sharing of resources in teaching, training, continuing education, and research opportunities. And of course, we have to strengthen research and development in health. Schools need to strengthen their research and development in terms of health. One of the functions of every higher educational institution is aligned with the plans of the WHO. Every institution should accelerate innovative research and development programs to help contain the spread of the pandemic and facilitate care for those affected. Next is to support research priorities that contribute to worldwide research platforms in hopes of learning from the present pandemic response to better prepare for the next unforeseen epidemic. And within these global changes, it has affected the overall education institution, and there is a great need to study on how each sector in the government will evaluate the scenario, plan, and implement such policies and programs in responding to the crisis. So let me end with what we are doing right now, enabling distance education and online learning for tertiary education. We have to, of course, address inequality in connectivity. Students and most of the time faculties as well do not have enough connectivity and devices at home. And this is particularly so for the remote and the poorest. The digital divide remains strong between countries and within countries. International bandwidth and local server capacity are not designed for the massive load that is coming. So academic staff capacity to deliver remote courses, faculty are often underprepared to deploy content even up to this point, a year and a half after the school closures. While most faculty members are active online, many have not taught in the online mode before this crisis. While there is a lot of material online, there is little 24/7 technical and pedagogical support available. Student capacity to adapt, many of, if not most students are not experienced as online learners. While they may be quick to adapt, students face challenges that lead to dissatisfaction with their academic experience. And of course, we have to learn with the mistakes. We need to learn by doing, but we also need to make sure that we can minimize their impact and correct as they are identified. For instance, contracting with service providers must be developed very carefully, particularly with regards to contract length, exclusivity, security, and privacy questions. And then finally, the regulatory environment is not yet aligned to online learning. A key issue is the competitiveness of some of the telecom markets, which often favor monopoly and does not provide cheap options that work for the poor. In many countries, quality and assurance systems are not helpful to improve online delivery. And finally, while regulation and privacy and data has been increasing. So hopefully, we educate, though the digital divide exacerbates difficulties in adjusting to flexible learning, but innovations and adjustments will emerge. The academe must be participative and be more willing in adjusting and exploring creative methods of teaching. And from now on, flexible learning will be the new norm, and teachers must realize that old norms are gone and they must adjust to new standards. So that's my presentation. Thank you very much, Terima Banyak. Maraming salamat po. It would be my pleasure to entertain your questions.
Maraming salamat po. Thank you, Dr. Calvin, for wonderful speech. Yeah, and when you present, I've got 3 questions, maybe 4 questions for you and for other speakers. So now we have Q&A session. So I have to read some of the questions. We have 5 questions from Q&A chat box, and also maybe 1 or 2 questions from chat box. The first question for anonymous attendee, they don't want to expose their name. I've got 2 questions. The first one from Bahasa Indonesia, but I will try to translate it. So I will share to you the question. The first question, his or her, not mentioned for which speaker who they want to ask. The first question is, how many years does the curriculum change at your university? It's related to the second one. Has there been a change in curriculum or study material during the COVID-19 pandemic? Maybe some of you already answered that question. And the second one, I think, is related what kind of competency or skill that we should prepare to face in this uncertain situation. Should we have specific competency or skill? And I think it's specific to public health curriculum. Thank you. Maybe Dr. Safi, or maybe Dr. Betty Chu, or Ibu Agustin, or Dr. Calvin, would you like to answer? Who wants to answer first?
I can try, if you allow me.
Yeah,
I can give you an example. The curriculum, I'm so thrilled. That's a very nice question to whoever make. I give you an example in Canada. So when we closed down in March 2020, 18 of March, and then we are almost middle of or end of the semester. We call this winter semester. Usually in Canada, semester is April, is a spring semester, and then fall is September, and winter is December, January, February, March. So in the end of the semester, we in crisis. University shut down, and right away, university build the infrastructure by training the instructors very quickly to switch from classroom delivery to the online delivery. So then open the 24 hours tech support, and then train instructors and make a webinar for the students how to make it. Then we decide synchronized, asynchronous model of teaching, and then from March to May, June, we started. So because of is a problem happen as an emergency, and when you have emergency, you need to act rapidly. And actually, techno support, university management, student, faculty, all are excited to learn new things, the new way dealing these things. That's why it depends on your university management capacity and the resource allocation. Then there is no time frame, 1 month, 3 months, 6 months, but it's a gradual process, step-by-step process. We are in a situation, we make it within 3 months or 4 months, still is improving. So as we go, we are improving. That's the number one question. And the second is skill. Skill is very interesting because all education in the past, we in our age, we just try to memorize and bomb it in the exam, and then we got degree. That is no more valid at all, honestly speaking. Now we need to see what is the real life problem and how to solve the problem. Industry, they have challenges. They come to the university, we find the solution for them. So that's why skill and competency is required. Example, if you think about the technician, about the electrician or water plumber or whatever you say, so university prepare and give you the toolbox the student will use. So if electrician use the water toolbox, it is disaster. The electrician use the water one is disaster. So university give the competency, the which toolbox you must use in the situation. So based on industry, they must select their tool. That is my my suggestions. It's nothing that I can give you 1, 2, 3 list is endless. So it depends on the organization, the needs, and the possibility, and also resource availability. Okay, that makes sense?
Yeah, that's very clear. Maybe Dr. Betty Chu, would you like to add some? You're mute, I think. Dr. Betty Chu, yeah.
Okay, I have to unmute myself. Okay, I think the previous speakers and the lectures already explained a lot of the change. So, for example, in my university, we are required to open new courses involve big data analysis or artificial intelligence, AI, in every department. And also, we are required to have 4 English courses, more and more every year. So my advice to the students or the younger generation is just you have to keep open-minded. Don't be afraid of learning new things and new areas, because nowadays the knowledge can be achievable and can be acquired so easily. So the new trend is you have to be able to train yourself to adopt multidisciplinary or cross-disciplinary area or courses, and just keep exploring new things, because nowadays the new technology just advanced so fast. Even the professors, we have to learn new tricks every year. So just let's learn together and move on. Thank you.
You're on mute, Loveria. Miss Loveria. You're on mute.
Sorry, no, I'm mute, yeah. Okay, thank you, Dr. Betty Chu. It's more clear right now. Maybe Dr. Calvin, would you like to add some? So all of the participants can more understand all of the question that before. Thank you.
I think it was already addressed by Dr. Shafi and Dr. Win. Yeah. Dr. Betty, I should say. Yeah.
Okay.
Yeah.
Okay, thank you. So you don't want to add something, yeah? Okay, I have another question from Bapak Besral, especially for Dr. Safi. Thank you for interesting presentation. Can you tell me more detail regarding universal health coverage in Bangladesh? And how is the COVID-19 pandemic affect this achievement? And Pak Besra have three questions, yeah. And is there a special role from students or graduates of public health education in this issue? Dr. Safi? Yeah.
Very, very good questions. You know, I am away from Bangladesh last 20 years, but due to COVID and due to working in the academia, I have access to the information digitally. So thanks God, I could able to answer.
Like so, you.
Yeah, Bangladesh, one of the country in Southeast Asia who can see the indicator of the MMR, IMR, or girls' education, all these things is getting better and better. So I could say, safely say, the primary healthcare is accessible, and the infrastructure from the rural level, as you say, know, the posyandu in Indonesia, in Bangladesh, we call a community clinic, one of the attractive things. So our prime minister and the government and the NGO, they bring this to the grassroots level, where people can easily go and access the service they need. Example, emergency obstetric care is to find the service, and immunization, family planning, all the health promoting tools, and so on. That's why I would say Bangladesh in the innovative highway of development of such a huge populous country in the world. I should say 170, 180 million population. So where I stay now, I'm talking in Canada, my second home country is just 37 million, but we spend billions of dollars for any initiatives because Canada is a GA7 country. So in terms of resources, we have a limitation. Still, people have the access, and they have this support service in place. And you know that government alone cannot serve everyone. That's why you all know here that Bangladesh is one of the NGO-nest country in the world. They have a huge #1 NGO in the world. You know the BRAC. They are very famous. Their community services, including safe delivery program. And now, last 10 years, we also launched in the maternity clinic in Indonesia. You are very familiar about the maternal child handbook, which is helping the mother to promote, to empower women to bring the security of the family through this initiative. So I would say Bangladesh is in the right track to cover, to address, but only backstory is we are a little bit behind about the health insurance system, so which is under development, is scaling up slowly but surely. And what is the other questions you have?
Yeah, we have another
last part of it. Last part of it. How is the last part? I forgot.
I will share screen first. Yeah, this one, special roles.
So COVID and a special role of graduate or public health education in this issue. Okay, this is interesting. It is miracle even staying in Canada, as we learned from Dr. Ya, when very nicely how Taiwan is make a history to control this kind of thing. Like mostly interesting attract me, mobile tracking, contact tracing, and this kind of thing, and restrict people's population movement is phenomenon in Taiwan model. I think we should follow. But Canada even failed to do that because we have so many right people and government cannot do it. That's why we are not in a position. We just need to inform people, please stay home. But in Bangladesh situation is so many population. People need to work to survive. So people never listen to what government is saying, what television is saying. People just need to go out and work. So, but still, you could see the death amount is total 9,000 plus less than the Canada. You know, when the population is 180 million, death is 9,000 is not significant to me. Every death is important, but it's the number if I calculate. But in Canada, 37 million, we have a 9,000 over death. So you could imagine, and now the case control is less than 2% of diagnostic cases. So Bangladesh is doing very well. And in terms of graduate student, I'm sure all we know, and we are the graduate, even Augustine, Dr. Augustine, we graduate in a department from volunteer studies. So the US, the Japan, all developed countries is volunteer service is so much popular. Even in Canada, we have a work-life balance. We want people to work 9 to 5, after that stop computer and go to the family or go to the community to work and support. I'm not sure this culture yet spread out whole developing countries. Still, we need to wait. But I think that is the challenging part in developing country, to involve graduate students, to leave the city, go to the rural area where there's not so much internet available, then they can work. I think this is the struggle. I think this is the real challenge in future, to ensure every people have the access of the information, every people have the access to the road and housing, then they can serve. But is work in progress. I don't think 100% we can say we are there.
Okay, Dr. Shafi. Some of the issue in Bangladesh is quite the same with Indonesia, I think, about the COVID situation, yeah. And also, thank you for the answer. I have to move to Dr. Betty Chu. We have another question. 2 minutes. Yeah, this one from Raihan Nadra Alkaf. Thank you for all presenter. My name is Raihan Alka from the Faculty of Health Science UIN Sarif Hidayatullah Jakarta, Indonesia. I would like to ask to Dr. Yawan Bedichu, what do you mean of aggressive combat and correct fake news? What kind of strategy for aggressively combat and correct fake news among aging people?
All right. Thank you for the interesting question. Actually, our infodemic was pointed out by the International Organization, not me. It's a new word, and it means that fake news or incorrect news will also cause pandemic or panic. So in Taiwan, sometimes because of social media are so well established, and sometimes the wrong concept or wrong knowledge, wrong information will be spread out so quickly like virus. So in the beginning of this pandemic, we already know that we have to control this, like controlling the virus. And we learned it from part from the 2003 SARS experience. Because if the rumor or wrong news comes out, sometimes you will just defeat or break down the confidence of the people, and the people will trust the government, which will become a political crisis. So anyway, this time our the measures we took is that our command center will host daily press conference and has published at least one press release every day since last January. And we use official website, official line, and Facebook to issue the data on the outbreak situation, and these survey results are all provided in a very transparent way. And also we enhance the capacity of our 1922 line, which is provided in a manner of 20 hours a day, 7 days a week. You can always call, report the case, or ask any questions, and the personnel they will answer the question. And also, just like I mentioned, for the aging people, the the senior citizens in Taiwan, they like watching TVs. Sometimes they use Line, but they like watching TVs. That's why our command center always have the first conference every day in 2 p.m. sharp. So all the older people, including my own parents, they are both more than 80, 30 years old. They will watch TV and at 2 o'clock every day, and they see, oh, what's the new outbreak situation, and they know that the first conference hosted by the Ministry of Health will be the most correct. And also, we have a lot of medical and health-related professional association and societies. They will also help review the current evidence based on international journal papers or any other news from the CDC, from WHO, and try to make it simple, summarize, and make it easier to be understood by the general public. And the third thing is that in the later stage, Taiwan government also authorized some professors. They established a so-called fact check center. They will catch the news very quickly and try to figure out or check if this is correct. And then if it's wrong, they will correct it as soon as possible. And the way they spread out the correct news can be through the, once again, the very common social media, like Line or Facebook or any channel we can use to combat together. So I think this is a very important issue in Taiwan, because sometimes we also found that some news were made up by the other side. Whoever wants to break down Taiwan's border and the guards. So this is very important, because cyber security is also national security.
Oh, wow. I just have a burning question, Dr. Betty Chu. Who is doing that? Only Ministry of Health, or you have a special minister who's focused on social media mining?
Oh yeah, yeah.
I'm just wondering who doing that.
Yeah, we use all kind of very advanced ICT technology to help protecting ourselves. Because as you may already know, we are not a formal member in WHO yet. We are still fighting for it. And sometimes the information channel or global network doesn't include Taiwan yet. So most of the time we have to depend on ourselves and protect ourselves. And of course, we have some reliable partners or allies, like US CDC. They are very good friends of ours. And sometimes we will ask them to help check if the news is correct. And sometimes also because we know different languages, so we will also share our information with some other friendly countries. That's how we protect ourselves. But I have to admit, advanced knowledge and technology is quite crucial to Taiwan. Yes.
Okay, thank you very much, Dr. Betty Chu. It's very clear right now. I can understand more clearly. Okay, maybe also the other participant also can understand more clearly. So we still have a few questions. The question is come from Baba Besal, but to Dr. Calvin. Thank you very much for your interesting presentation. The question is about the COVID-19 pandemic has changed learning method from face-to-face learning to online learning. Can you tell me more detail regarding impact of the COVID-19 pandemic and this change in learning method on the mental health of a university student? And the second one, how is the faculty effort to overcome this? Dr. Calvin, the floor is yours. Yeah.
Thank you very much, Besral, for your very interesting question. Actually, there are efforts on mental health, in the University of the Philippines. At least I could say that. But to give you a little highlight, let me. In the Philippines, I should say that we are most affected of switching to online learning. For one, because Filipinos are very social individuals. No, we love going out, we love being with our friends, etc. So definitely, the students being cooped in their rooms, had an effect in their mental health status. There is actually some information that one of the highest rates of depression in Southeast Asia, affecting more than about 3 million Filipinos, if I remember it right. But fortunately, in the Philippines, we do have the just recently, the Mental Health Law, Mental Health Act, approved. So there should be a number of interventions. It was actually enacted in 2018, prior to the pandemic. And it aims to establish a national mental health policy underscoring the basic rights of Filipinos to mental health. And it aims to enhance the delivery of integrated mental health services, promoting and protecting the rights of every Filipino to access mental health services and facilities. So this means from the primary healthcare level up to tertiary, it's readily available mental health services, even at the barangay or the community level for access. But unfortunately, because of the pandemic, it would be really hard to access it even on those levels. So what we do in the university is that we have mental health and psychosocial support, activities. We also opened through the help of the Philippine Mental Health Association, some you could call or phone them, at times, those support networks, and we keep on reminding students that they have someone to actually reach. And also the faculty members, we attended some online trainings, but only for first aid, psychosocial first aid. That's all we could do. And we try to give them options, numbers to call, etc., professionals to contact, just in case they would be needing some help. From our case, at least we try to communicate to our students, to be more personal, at certain level. But it's at the same time, the faculty members needed, some time off, So ourselves, also are very mindful of our mental health status. So there are several activities, and I believe this is not unique in the Philippines. It's also in some other areas. But in addition to the latter part, of course, the switch from traditional to online, not all of the modalities, not all of the evaluation of students will be applicable. If we try to apply them in the online setting, it would be too tedious for the students. And it will be too much for them to handle. So we try to adjust, and as I mentioned earlier, we learn day to day, every day, on how to improve our learning modalities in order for it to be easier, not only to the students, but also to us. Yeah. I hope I answered your question. Thank you.
Yeah, thank you very much, Dr. Calvin. Yeah, I think it's quite clear. I have the not the last question. I still have two questions at this moment. Few minutes. I will share it to you. The question to all of you, to all the speakers. The question is about the first. Okay, I will ask the first one. From SQ Alive. Maybe he don't want to mention his name. We know that to achieve the public health being optimum is need multidiscipline science. In your point of view, taking about undergraduate level education in public health, what do you prefer? General curriculum of public health science or concentration curriculum that in Indonesia doing now? Maybe Dr. Safi would you like to answer, because I think it's related to your presentation.
Yes, I love this question. Thank you very much. because I consider myself as a developer, builder of curriculum last many years. So you will be know that now I'm building one of the committee as Canada. Every 20-30 years later, we build the medical school. So in Canada now we are progressing new medical school, and we have a 35 or 39 member planning committee. I'm one of the committee, and I'm a member of the curriculum and EDI, admissions. And I found that interesting in many aspects in developing country, the politician or the community leaders or somebody, the dream, we need to build a university or college or medical school. They just make an announcement, well, we have a medical school, we have a university, because the health and education is the political football. Many countries, politicians, they love it to say it, and they throw it, and they get a vote. And after that, everything disappears. No quality, no curriculum, nothing in place. Somebody got some position and some fancy things and so on. But in Canada, I can tell you, but even in Thailand, when I graduated in early in 2000 or 1999, I found the undergrad public health is very strong basis. If I look in Bangladesh perspective, I don't know much about Indonesia, Philippines may have. I cannot give you a big list that where you can see undergrad public health degree program. There is a life science program. There is a program for study for biochemistry, biostatistics, whatever, but there is no stream like that significant. We can say BSc in public health. There are few, it's negligible. But in Thailand, if you think about the Mahidol University, all you know, which I'm graduated, proud of, you can see when I was a master student, we are like a 35 international students or master student, Thai pharmacists or doctors, nurses, midwives, we have another 50 or 100. But we saw there's hundreds of undergrad public health degree people, and where they study the fundamentals of all the things we study in master degree. So that's exactly need to be that way. That, like example, we study in high school some math, physics, chemistry, and then go for university. We need to expand the horizon a little bit applied way. The same undergrad level should be that way, like fundamentals of bio, fundamentals of EP, fundamentals of analysis, this kind of thing. And after that, in masters, you will be the master of that one. So I want to study about the EP or primary healthcare or urban health. Specialization is the professional degree. Actually, main foundation should be built in the undergrad level. Guess what? I was a physician. I was an anesthesiologist. I have no idea about biostat. I have no idea about epidemiology. I treat people. I just give you the slip. You sleep, surgeon operate. That was my job. But now when I go there, I need to find the data. I need to find the methods. I need to learn the SPSS and whatever, and I need to analyze. This is very new to me. It is very stressful. But guess what? If I have this introduction in bio in my undergrad medical school or statistics, that would be more easier for me and to mature my ideas. So it doesn't make sense to me. We don't have public health undergrad degree program in all the universities, those who run the master degree. The matter of the fact, the problem is many developing countries, medical school taught this is their duty to teach them in the master MPH course. Then their graduate will be the MBBS or MD plus MPH. Then they'll be more sellable. This kind of selling viewpoint is not the student viewpoint. So we need to think about student viewpoint, how they can get benefit, number one. And what is the second question? So curriculum need to be embedded foundation in the undergrad for sure.
Yeah, it's quite clear. And I think I can see Dr. Betici smile and Dr. Kelvin smile. I think this is debatable question. Dr. Safi, or you already give us an example, is quite clear for us. I want to hear another perspective from Dr. Betici and also Dr. Kelvin, because Dr. Safi just give us some example from his perspective and his country. But I think I also want to hear from Taiwan and also Philippines. So the first one, I give the speech to Dr. Betty Chu.
Okay. I actually agree with the answer that Dr. Shafi just provided. Perfect answer. Okay. I don't know what's the general or concentration curriculum in Indonesia. I can only guess, but I guess it should be similar like Taiwan. There may be a debate between these two kinds of settings. However, just like I said, I agree with Dr. Shafi. Because there's an old saying in Taiwan, study is like building pyramid. You need to have a wide and strong foundation, and also you will pursue the height in the end. But for the question from the audience, is asking about the undergraduate education. So I think foundation theory is very important. It has to be one, more exploration and strong. And then you find your interests, then try to mature and concentrate on something more professional. Thank you.
Thank you, Dr. Betty. We have to strengthen the foundation. Yeah. How about Dr. Calvin?
Well, I'm a product of Bachelor of Science in Public Health. So my answer would be, it really depends, because for me, when I graduated, when I was trying to enter the university and took the course of public health, the idea was for me to get into a good med school. It's a stepping stone. It's a pre-med course. So it's really a question of why is the program created? What for is the program? And just recently, or if not recently, about 5-7 years ago, when I was still teaching at another, how should I say, campus of the University of the Philippines, Manila, the Department of Health actually created a position for BS Public Health graduates, as a public health manager, But somehow, it didn't encourage the public health graduates to be part or to work for the government because one, their mindset was already becoming a medical doctor in the future. No, as I presented earlier, I think I'm not pro or against, but to me it really depends on how it is packaged. Certainly during my time, it's packaged as a good pre-med course. But if it's going to be packaged like, especially now, we need more public health managers, and available positions. That's the thing. We don't have available positions. So therefore, who would want to become a public health expert, after a BS degree? But the good thing is, in the Philippines, we do have our graduate programs. So there, I do agree with Dr. Shafi and Dr. Betty that now you could see, like if you feel like going to epidemiology, nutrition, etc., you have several options. But for someone who's graduating, fresh graduate, like we are hoping that when you graduate, you could, like any nursing students could be a nurse, any physical therapist could be a PT, etc. No, and in addition to that, the BS Public Health degree could you could become a BS Medical Technology. How should I say, licensed medical technologies in the country, because we don't have in UP, we don't have a medical technology course, so it's like a alternate. So the question remains like, what does your country need? There.
Okay, it's more clear right now. Welcome back, Ibu Agustin. We have a debatable question, but Dr. Safi, Dr. Betty Chu, and also Dr. Calvin have the same answer. Focus on strengthen the fundamental of public health. Ibu Agustin, would you like to add some answer?
Yeah, thank you, Lofi. Lofi is also Bachelor of Science in Public Health. So similar to Dr. Calvin. And I have many graduates as a Bachelor of Science in Public Health also. And in fact, that actually the current curriculum of Bachelor of Science in Public Health, Indonesian curriculum, is a generalist curriculum that we developed the curriculum, designed the curriculum to give the what we call as a core public health competence that will consist about 60 to 70% of the whole curriculum. And then another 30 to maximum 40% will be the top up, will be the, example, if we have the pizza will be 60 to 70%, and then the topping will be 30%. The students can select whether they are interested in a certain major, such as reproductive health or epidemiology or biostatistics or others. But it's actually a topping. So the main competence designed to be given in the curriculum is the core public health competence. And then we also believe that, or we also design that the specialization will be happen after the bachelor degree. So it can be, we in Indonesia, we know that there is a level that we call as a professional education. So can be, if we see the levels of expertise, we have level 1 to level 9. Then Bachelor of Science is level 6, and then we have level 7 for professional education, and level 8 for master degree, and 9 for doctor degree. So actually, we are developing a program that commit to provide core public health competence. The problem is the available positions within the Ministry of Health doesn't say like that. They open the position for epidemiologists. They open the position for health promoter. They open the position for occupational health officer, something like that. So in this case, we have to respond to the need of our users in such a way so that besides giving the core public health competence, we give adequate topping so that our graduates can also grab the opportunity that given by the system, by the Ministry of Health. So the situation is like that. So for example, in the industry, in the mining industry, in the factory, they are not looking for public health specialists or public health professionals. They are looking for occupational health specialists, either in the bachelor degree or in master degree. So in this case, that's why we need to give, if a student have a passion in occupational health, then we can say that our graduates is a Bachelor of Science in Public Health, majoring in occupational health. So that's the system in Indonesia right now. So some people feel that actually at the bachelor level, the major or specialization is not appropriate at that level. It should be at the higher level. Maybe after that, the professional level or master degree. But the problem is our market, our users have different way of thinking. So in this case, we have to adjust also our curriculum, our product, so that our product will be matched with the need of the users. That's the situations. But actually, if you see the curriculum, if you see the program, we are stick with the concept that Bachelor in Public Health acquire a core public health competence. The specialization, the major, is a topping. Sometimes it's not adequate. So usually in the university, we have a big argue between those who want to give more specialist knowledge and skill, and those who want to build a very strong fundamentals of public health. So it's already a very long debates in Indonesia. Since the first time I joined the Faculty of Public Health in 1987, the topics is always there. Generalist versus specialist, always there at the bachelor level. At higher than bachelor level, no problems. So I think we have to be we have to be to be a little bit strategic. I say it strategic to see that we want to build a very strong fundamental of public health competence, but we also want to give the ability to our graduates to be able to grab the opportunity. So everybody go to school at one time, they think that they can work using their knowledge and their skills. So in this case, we have to take into considerations what our users say about the characteristics, about the competence of the graduates that they want to employ later on. So that's my opinion. Thank you.
Okay, thank you, Eva.
I want to add something.
Want to add something. No, the floor is yours.
Yes.
Please.
Yeah. Dr. Augustine, my friend, she explained everything very nice. I am now hungry now because she talked about pizza. When people talk about food, I'm become very hungry. Anyway, it's very good analogy that you think about a pizza. The more the topping you make, the more delicious, more expensive. It's very true. But nothing wrong with undergrad with some major or minor stream. In the University of Toronto, we have those degrees, undergrad life science, but they have a major in neuroscience, major in this and that. We all have those kind of things in this country. So that is nothing wrong with that. But I want to add something that Dr. Augustine mentioned, strategic. So we all producing the product to sell to the market, right? If market demands that direction, we must follow that direction, but it will take time to change the industry demand. So you have to explain this, get out there. So then you can change it. But we don't say it anymore in developed nation, mostly the student. We call about lifelong learner. So that's why learning is endless. They are undergrad students, and then they go for a job. And during the job, they come back to the university as a continuing education program. The continuing education program is one of the cash cow of the university. They make a lot of money than any faculty they make. So because the people going for a job and they realize, wow, my teacher or my class never teach me how to prepare a report, how to present this to the boss, how to communicate or sell this as a business model. So then they become freak out and they become pressure, stressful. That's why they come to the university, not for the degree, they call it certificate or a special certificate. The things they need based on the industry, they just come and they just learn. And then they go back and they promote from managerial position or director position. So they don't need master degree. They just have the experience foundation and they understand what is their gap is, and the continuing education fill up the gap. That's why now more dynamic is coming. Augustine rightly mentioned micro-credential. Now university is not even thinking to launch a year, month-long certificate. They just want to go to you, Lovera, that Lovera, your faculty or your industry need what kind of training? You said, I need a training of project management. And then we design the program like a 30-hour, 10-hour boot camp and invite your staff to join, customize based on your need and the money. And then we give you all the nuts and bolts. And then they go back and they become productive. So education system is changing. Market demand is changing. So now we need to just follow each other. So that is collaboration. Thank you.
Okay, Dr. Safi. I think it's more clear right now. Okay. Even maybe some of the participants still want to ask some question because some of them already sent a private question to me, but I cannot I cannot read all of the questions. So because in Indonesia, our time is now almost 6 p.m. and it's praying time for us, and I also have to close this session. Yeah, but even I think we still want to hear a discussion in session. Yeah, but in this event is about to come to the end. So the excellencies, distinguished participant, and ladies and gentlemen, we had the productive and inspiring time together in this symposium. I hope you found the presentation on this conference an informative and helpful information. I would like to now call upon Ibu Agustin Kusumayati, MSc PhD, to present us with the closing speech. Ibu, please.
Okay, okay, thank you, Ibu Lofi. Ladies and gentlemen, so finally we have to end our very exciting discussion because the time will not allow us to continue. So for these occasions, let me deeply thank for all the resource persons, Dr. Betty Chu, Dr. Shafi Buyan, and Dr. Calvin. Thank you so much for your valuable contributions during these symposiums. I believe that many of us are really triggered by your presentations, by our discussions, and it will give me more headache because it will be discussed within our associations. So the discussion will be continued. Tomorrow we will have another discussion still about the curriculum of the Bachelor of Science in Public Health programs. So again, thank you so much, Dr. Betty, Dr. Safi, and Dr. Calvin. I hope we can meet again in another occasions in a better situation. Maybe we can meet in person, maybe in Taiwan. And let's pray that the pandemic, we can control the pandemic. Our God Almighty lift up the pandemic from our only one world, and then we can live normally. Again, thank you so much. And I conclude the symposium. I end the symposium with the pray to thank our God Almighty. Alhamdulillah alamin. Assalamualaikum warahmatullahi wabarakatuh. God best blessing for all of you. Thank you.
Thank you. Thank you, Agustin.
Thank you.
Thank you.
Bye.
Thank you.
Okay,
Bye.
Yeah, thank you, Dr. Safi, Dr. Calvin, and Dr. Betty.
Oh, thank you,
Yeah.
Lavera, for a special thing. You did very good job.
Thank you. I also have one verse from us. In bahasa Indonesia, kalau ada jarum yang patah jangan disimpan di dalam peti. Kalau ada hilaf yang salah harap sudi dimaafkan. It means please forgive us. Please forgive us for our shortcoming. Okay, we meet again, perhaps with next agenda from Indonesia. Or
no,
maybe
I really enjoyed. You know how excited I am. I wake up 3 o'clock at midnight because I would like to see my friends and share our knowledge and exchange. I really happy to see Calvin and Dr. Iya, our new friend. Maybe we will work together to make the global health in a manner the young generation can inspire, and they can join us, and we can change the world.
Yeah, thank you, Dr. Safi.
Can change the world.
Yeah,
This is what I like from Safi.
Yes.
Can we have photo session before we leave?
Yes.
Okay. Sure. Okay.
Okay, change the world.
Yeah,
Okay.
change the world. Okay. Okay. Wow.
Bye.
Thank you.
Okay. Welcome to Taiwan. Bye bye.
Thank you.
Bye bye,
Bye-bye.
Betty. Thank you, Betty. See you on the 4th. See you,
Yes.
Betty, on the 4th.
Thank you everyone.
Thank you, Calvin. Thank you, Safi.
Thank you.
Thank
Goodbye.
And my best
you.
regards for Nini and the children.
Thank you, Dr.
Yes.
Betty.
Thank you so much.
See you.
Yeah.